All right, so this is the second part of my talk. This is where we talk about how to stratify your disease into local, focal, zonal, or diffuse disease. I think this is a very important concept when you're thinking about doing battle with prostate cancer. So at this point, I would advise you to put your safety belt across your lap and buckle and keep your hands and feet within the vehicle at all times. So we're going to talk about local recurrence, focal recurrence, zonal recurrence, and diffuse recurrence of prostate cancer in the next portion of my talk. Local disease is pretty straightforward. It is recurrence of prostate cancer at the site where the prostate used to be or inside of residual prostate components. So causes of local recurrence of prostate cancer include regrowth of cancer after complete surgical open or robotic prostatectomy, growth of residual prostate bits and pieces after surgery or procedure. So what does that mean? Well, sometimes even surgeons will leave things behind after an operation. These are extreme cases where entire prostates were left behind after surgery, unbeknownst to the patient. So these are all situations where patient was told that their PSA was still there after the surgery and that they would need some further treatments. But what the patients did not know until they saw us was the entire prostate was still left in place after the surgery. Another cause of local recurrence is recurrence of prostate cancer within a prostate after it has been irradiated. And this includes external beam radiation therapy, stereotactic, brachytherapy, or proton beam therapy. Another cause for recurrent prostate cancer is after having both surgery and salvage radiation therapy. So let's talk about after surgery first. Prostate cancer can appear after an open or robotic prostatectomy. The way this usually is patient at first has undetectable PSA, but then over time, PSA starts to go up. You can have PSA start going up 20 years after your prostate has been removed. A lot of times, these are local recurrences where the prostate cancer is basically growing back by the roots somewhere in the pelvis. So sometimes the cancer can come back between the bladder and the rectum, or sometimes it actually can grow into the bladder, or sometimes it can be on the front of the rectum, or it can be at the site of surgery where the bladder is joined to the urethra. Sites of recurrence after prostatectomy have been mapped by my group, and what we found is that 33% of patients that have their prostates taken out and suffer a recurrence will suffer only a local recurrence in the pelvis. In contrast, 45% of patients who have a rising PSA after surgery will have what we call metastatic recurrence of prostate cancer. Finally, 22% of patients that undergo surgery and PSA goes up will have both local as well as metastatic recurrence of disease. To diagnose local recurrence after prostatectomy, you have to undergo a PET scan to rule out metastasis, MRI, and a biopsy. For looking inside the pelvis behind the bladder, MRI is the best for viewing anatomic details in the pelvis. And remember, only 33% of patients have pure local recurrence after prostatectomy. What this means is you should not get radiation therapy until you are absolutely certain about the kind of recurrent prostate cancer you have. You want to confirm that you're one of the 33% of men who have disease only in the pelvis at the surgical site. Local recurrences can be cured. There are ways of curing this fairly easily. Cryotherapy can sometimes be used to freeze the lesion. Other times we use radiation plus hormone therapy. This is probably our most common approach. When we do hormone therapy, we do it for 4 months before, 6 weeks during, and 1 to 1.5 years after radiation is given. If the recurrence is hormone resistant, then we usually use second generation agents such as abiraterone, enzalutamide, apalutamide, darolutamide, plus radiation to treat the recurrent disease. For patients that have recurrence after getting their prostates irradiated, 55% of the men will actually fail or have recurrent disease inside of the prostate. This can appear after any form of radiation therapy, brachy, proton beam, whatever. PSA is usually low, but then rises slowly over time. And the PSA rise can occur anywhere from months all the way to 20 years after radiation has been given, just like prostate cancer surgery. To find local recurrence, once again, you need a PET scan, MRI, and a biopsy. These recurrences can also be cured. Sometimes we will actually tell the patient that we need to remove the prostate, and removal of the prostate after radiation is both feasible and it can be done very safely with excellent function still remaining in the patient. Cryotherapy can also be used to knock out recurrent disease in the prostate. That means taking a tool and freezing the tumor. This is an example of case done by Dr. Lance Minders here at Mayo Clinic. This patient had a PSA of 10.7. A tool was placed into the prostate to freeze this area that's glowing. After the procedure, PSA dropped down to 0.31. Patient tolerated the procedure well, excellent results. If you cannot freeze the lesion, and if you cannot have the patient undergo surgery, it can be palliated. I hate using the word palliation, but it can be palliated with hormone therapy and second generation agents such as abiraterone, enzalutamide, apalutamide, and darolutamide. These are fancier forms of hormone therapy. Finally, you can have a local recurrence in an area where the prostate has been removed and radiation has been given. We call these in-field failures. I think we made it up inside our clinic here because we see so many of these things, but we call it in-field failure. This is one of the worst forms of recurrence for us to treat. Sometimes you can freeze these things, but it is very, very treacherous. Sometimes we have to take out a patient's bladder, urethra, and sometimes even the rectum to cure the patient. Obviously, that is a huge emotional step for a lot of patients. So for many of these patients, we will palliate, once again, with hormone therapy or second generation forms of hormone therapy because patients aren't ready to lose their bladder or rectum. And in these situations, I have to say it's a little bit like Falstaff in King Henry IV, Part 1. Discretion is the better part of valor. Caution is preferable to rash bravery. The reason that I say that is some patients will try to use minimal invasive approaches to knock out their disease and they get into trouble. This is an example of a fistula, and we see tons of these in my practice. Fistula is where the tissue doesn't heal and you end up with a connection, sometimes between the rectum, the bladder, and the pubic bone. Many of these situations are fatal. So in other words, sometimes if you go too hard on trying to knock out the cancer, you will create a secondary problem that is actually much worse than the cancer itself. For all forms of local recurrence, we advise regular 3 to 6 month follow-up, which I think is imperative for life. Anyone that tells you they fixed the problem and you never need to come back, I think you should rethink that. You should always keep an eye on your cancer and get some follow-up. Follow-up should include PSA, MRI, and one day, hopefully, possibly PET scans at regular intervals. Now we're going to talk about focal recurrence of disease. Focal recurrence is also referred to as oligometastatic prostate cancer, first defined by Hellman and Weichelbaum for metastatic lesions ranging from 1 to 5 different lesions, okay? We actually rolled out discussions on treating oligometastatic prostate cancer 10 years ago at PCRI, And I'm very happy to say that this has become a very hot and accepted topic for the management of advanced prostate cancer. In terms of oligometastatic disease, our group has actually calculated that PET imaging can find recurrent cancer 7 years in advance of what was previously possible using conventional imaging. On average, most of our patients will have their first sites of prostate cancer, either metastasis or recurrence, identified by the time their PSA achieves 2.0 nanogram per ml. 12% of our patients will actually have spots identified even when their PSA is undetectable, and we'll talk more about that later. Based on our experience, we predict that with increasing use of PET imaging, oligometastatic disease will soon become the most common form of recurrent prostate cancer seen worldwide. My clinic sees approximately 6,000 patients annually, and here at Mayo Clinic, we do about 42 to 4,500 PET scans per year. In our practice, 52.5% of our patients have one spot and one spot only of prostate cancer due to our strategies for early identification of recurrence. Here's an example of a solitary recurrence in the C6 spine of this individual up in the neck, PSA 0.14. Here's an individual with a PSA of 1.7, recurrent disease in the pubic bone. You can see it clear as day. Here's a gentleman that has a PSA of 0.33, and it's growing back as a solitary metastasis in the adrenal gland. And we just pluck out the adrenal gland, disease went away, patient's doing perfect 5 years later. Here's a gentleman that has a PSA of 3.5, and his cancer has metastasized to the very tip of his penis. This is a solitary metastasis in the tip of the penis. Here's an individual that has this curious lesion right next to his belly button, PSA 1.7. So how on earth does prostate cancer end up next to the belly button? Well, this happens to be the place where the robot surgery port was placed in. The robot arm went into the body, and as the port was being removed, it must have contaminated the port site with prostate cancer. So we actually published a series of these as proof positive that you can explant cancer from one spot to another by basically instrumenting or manipulating the cancer surgically. So that was the first time ever report of that, and that has been reported. So a lot of people will say, well, why would you want to find prostate cancer so early? It's not causing any problems. And to those people, I say, well, there are advantages to finding it early. If you find prostate cancer early, you're going to be dealing with less numbers of spots in the body. And also the size of the tumor is going to be small. And also the heterogeneity of the cells is going to be less, meaning there are going to be less mutations associated with the disease. And obviously the big advantage is if you can find it, you can kill it. It's amenable to definitive therapy. Back when I first started talking about doing all of this 10 years ago, people said, oh, baloney, that's not possible, that's not doable. Kwon, you're all wet, okay? And now I have to say that I'm very happy because a lot of people have taken interest in this subject, and we have incontrovertible evidence that this kind of approach can be hugely successful. For instance, with hormone refractory prostate cancer, it was previously reported that if you have hormone refractory prostate cancer and you stay on hormone therapy, median survival would be 0.9 to 1.7 years. That's a short period of time. With the newer drugs like abiraterone and so forth, you may be getting a little bit of a bump in survival, 1.5 to 4 years thereabouts. But then we have these patients that we treated so many years ago where we found hormone-resistant prostate cancer, and we've done things like treat it with surgery, PSA 2.5 while on hormone therapy. We pluck it out, and then years later, 5 years, 8 months later, no evidence of disease. Patients not on any further therapy. Likewise, this gentleman that I presented way back when, PSA 1.2, hormone-resistant disease, L2 spine, treated with radiation. 9 years later now, no additional therapy. Here's a gentleman with one spot on his breastbone. And once again, it's weird, but we see a lot of these on the breastbone. Treated with stereotactic radiation, hormone-resistant disease, PSA 2.7, down to 0. 8 years, 9 months later, no additional therapy. To me, that's incontrovertible evidence that finding it and knocking it out is much better than what used to be done, which is just let the disease play out and let the patient die in 0.9 to 1.7 years. So I think that the evidence is growing every day that targeting these lesions is very advantageous for the management of patients. When we treat solitary metastasis, it depends on location. Bone, if it's in the bone, we freeze it or we use pinpoint radiation, stereotactic radiation. A lot of these methods initially were rolled out by our radiation team at Mayo Clinic, who shot at these lesions left and right and proved that it can be highly beneficial for patients. If it's in a lymph node, you can freeze it, you can remove it surgically, or you can irradiate it. If it's an organ, you can use cryotherapy or surgery or radiation therapy. Usually, if we see one spot of cancer, we do not use systemic therapy. We want to know beyond a shadow of a doubt, did we get all of it and is it going to stick? So we don't use systemic therapy with these lesions. In order to follow patients, we get PSA every 6 weeks and follow up with the patient every 3 months thereafter. If a patient does have recurrence after treatment of one metastasis, we have to be realistic. If only one spot appears after a long delay, we'll try again. If the recurrence is at the same site, we will try again. However, if the PSA doesn't go down or starts rising after you made that spot go away, then you got to start thinking about something else. If the cancer or if the PSA starts to come back as multiple recurrences or the PSA starts skyrocketing, you better think of alternative therapies, including systemic treatment of disease. For oligometastatic, this is anything but solitary, 2 to 5 lesions, depends on location, can be treated with all the same tools, radiation, freezing, surgery, whatever. The more the metastasis, the worse the results. So when you start pushing 3, 4, 5 lesions, you're probably not going to shoot them all down. Results also worsen if these spots are far apart from each other. Usually, if we start to see lots of spots, we start thinking the Deluxe treatment package. And I'll talk about Deluxe treatment a little later. I'm very happy to report that multiple studies have now shown that directly targeting oligometastatic disease can eradicate the cancer or profoundly delay requirements for next forms of treatment. This is increasingly more an accepted form of therapy worldwide and nationwide. And I'm very happy that's the case because I think it works very, very effectively for patients. And obviously, lots of publications have now come out to support this point of view. As with any form of therapy, focal recurrence, regular follow-up is imperative. Follow-up should include PSA, MRI, and PET scan imaging. Now we're going to talk a little about zonal disease. Zonal disease looks a little bit like this. So zonal disease is not a real medical term. It's a term that Kwon made up, okay? So I just made this up because I thought it sounded good. Focal, local, zonal. I thought that sounded kind of cool. Zonal recurrence means a large clustering of prostate cancer or recurrence of prostate cancer within an anatomical compartment or zone within the body. So for instance, here's a guy that has a ton of disease in the pelvis, PSA 9.2. These are lymph nodes. Here's a gentleman that has a ton of disease only in the retroperitoneum. That's the space in the back of the tummy. Look at all those lymph nodes filled with cancer, PSA 7.1. Here's a gentleman that has his cancer growing back inside of the bladder. So that's a zonal recurrence, PSA 1.6. Here's a gentleman that has a PSA of 0.19, and the cancer is completely replacing his penis. So this is a zone. This is a zonal recurrence of prostate cancer. Here's a gentleman that has PSA of 31.2, but all of his disease is in the top part of his lung. And this patient was treated with surgery with excellent outcome. So zonal recurrences can be cured. Many of the patients I showed you, they've been cured. They can sometimes be treated with smart combinations of surgery, radiation, or hormone therapy. Oftentimes, when we see zonal recurrence, we roll out a deluxe treatment package, which is typically a combination of hormone therapy used in combination with chemotherapy and surgery or radiation therapy. So once again, deluxe treatment is not a real medical term. I'm just going to take a sip of water. Once again, it's a term that I made up to describe a rational and aggressive approach to force curative responses to treat advanced forms of prostate cancer. So what's the logic behind deluxe treatment? What could possibly be the logic other than trying to sound like McDonald's, deluxe treatment? Personally, it's my strong belief that the goal of treating prostate cancer should not be to force palliative outcomes, okay? The goal of prostate cancer treatment should be to force a curative outcome, not palliation. And this is a very important discussion because some physicians right now are against being super aggressive for small volume disease because they believe that the only outcome that is possible is palliative outcomes. I disagree with that, all right? So up until recently, the focus of treating advanced prostate cancer was palliation. Let the cancer get bad, treat it with something, let it get bad, treat it with something, etc. Use different agents until you lose control and then the patient dies, okay? To me, every one of these spots represents an opportunity lost in terms of knocking out prostate cancer. I don't like this outcome of failing with a lifelong period of treatment with an end that looks like this, all right? I like this kind of situation where you see the disease and then you go essentially very aggressive in terms of managing the disease to the point you hope that you can knock it out. And usually we use a mixture of approaches and treatments to try to force that outcome. I think this is a better outcome, and I call this curative therapy strategy. Another reason that I think deluxe treatment makes sense is cancer is not one cell. It's a whole bunch of genetically unstable cancer cells, all right? And my feeling is if you're dealing with a heterogeneous population of cells, you need a heterogeneous population of treatments to kill those cells. These are mixed populations of cells. If you don't believe me, just look at a Gleason scoring system. It basically is the realization of heterogeneity of cancer. You have Gleason 1 through 5, you have, 4 plus 3, you have 5 plus 2, whatever, It basically, everything about prostate cancer says heterogeneity. On top of it, you have cell types that people hardly ever mention. Neuroendocrine small cell subtypes, unclassified. I think Jonathan Epstein is going to be discussing how heterogeneous prostate cancer really is. So to me, if you have heterogeneous disease, you need heterogeneous treatments to knock out the disease. No brainer. Another reason we want the deluxe package is we can't necessarily see all the cancer in the body. And at times it is wise to presume that there are microscopic seeds of cancer elsewhere in the body. We typically don't fear what we can see. We fear what we cannot see in a patient, all right? And that's why a lot of times we will roll out a deluxe treatment package for their cancer. Finally, the part that just blows my mind, I cannot think of another form of cancer where they just use successive palliative treatments to manage the cancer. This is not what we do with breast cancer. Breast cancer is chemotherapy, hormone therapy, radiation, surgery. Boom, knock it out, right? So why on earth is prostate cancer treated differently than virtually every other form of cancer? Why not use a deluxe package to try to knock it out? So that's my argument for deluxe treatments. When we talk about treating cancer, we like to talk about 3 different forms of therapy. I call them suppressors, killers, and removers. Suppressors are forms of hormone therapy. They make the cancer get sleepy and go to sleep. It regresses the cancer, but doesn't necessarily cure it. Second generation hormone therapies are just like the first generation hormone therapies, but they're second generation. Zytiga, Xtandi, Erleada, Nubequa, abiraterone, enzalutamide, apalutamide, darolutamide. These forms of treatment put the cancer to sleep. They cause it to regress, but they are not known as cytotoxic treatments. The other thing that you have to know about these things is these drugs are somewhat redundant to these drugs. They all manipulate hormone utilization by cancer cells. So they work with one pathway for attacking prostate cancer. In contrast, killers are cytotoxic chemotherapy. These are things that will actually poison the cells and kill them. Taxotere, Jevtana, carboplatinum are forms of cytotoxic chemotherapy. PARP inhibitors such as Lynparza or Rubraca, these are agents that mess with basically processes in the cells to cause the cells to die. Likewise, these isotopes, Xofigo, 177, PSMA, lutetium, 225, actinium, they impart ionizing damage to cancer cells and they cause the cells to die. And likewise, if you freeze a cell, if you heat it, if you hit it with proton beam, stereotactic radiation, external beam radiation, you are going to kill cells. So we call those killers. And then the removers are self-evident. The removers are things like prostatectomy, surgical lymph node dissection or removal, resection of metastases. These are the removers of cancer. So when we talk about deluxe treatments, a lot of times we talk about using a suppressor along with a killer and along with a remover to knock disease out. And I got turned on to this approach very early on when I started my career at Mayo Clinic. I was contacted by a medical oncologist out in the community named Vladimir Hujak, and he told me that he thought that we are too gentle on the management of advanced prostate cancer. And he said that we should toughen up and get more serious. And he shared a patient with me that was 45 years old who had bone metastatic disease, spots on his T3 and T10 vertebral body. And he said, let's go wild on this individual and try to knock out his disease. So we gave this gentleman Taxotere chemotherapy in combination with hormone therapy far before Charted or Stampede trial was ever conceived or conducted. And then we irradiated these spots with radiation. And I actually presented that patient when I first spoke in 2011. 11 years, 7 months later, this patient is not even on hormone therapy. His PSA is unmeasurable. He has no evidence of recurrent disease. And he is leading a great life. And he's only in his mid-50s now, but he is very happy. And I feel very good for this individual. Likewise, this is a gentleman that was sent to me by my colleague, Dr. Carnes. Dr. Carnes is a surgeon here, but he thought that, this is even beyond his incredible skills as a surgeon. PSA 25,000. The gentleman was in liver failure, bowel obstruction, kidney failure. So we treated him with hormone therapy. We treated him with chemotherapy. We treated him with abiraterone. We whittled down the disease to little spots, and then Dr. Carnes went in not once, but twice to take out every one of these little spots in the gentleman's retroperitoneal space. And this person came to Rochester this month, and he came with his rock band and he gave a concert in Rochester, carefully, of course, because of the whole COVID thing. He's 10 years out, no further treatments. He's extremely happy and grateful for the treatment he underwent. So this is deluxe treatment of fairly advanced disease. So for zonal recurrences, just like every other form of recurrence, we recommend regular 3 to 6 month follow-up. It's imperative for life. We think that you should get PSA, MRI, and PET scans for all of these patients as possible.